Hey there, welcome back to Midnight Med. This video will be on labour. Now, labour refers to the process of delivering both the baby and the placenta. It is usually defined by and associated with powerful uterine contractions, rupture of the amniotic membranes, and dilatation of the cervix. Labour is typically divided into 3 or 4 stages. We will discuss it in 4. The first stage is from the onset of labor to full cervical dilatation at 10 centimeters. The onset of labor is defined by contractions becoming regular and spaced 3 to 5 minutes apart. Monitoring of labor begins in the first stage, with cardiotocography, or CTG, done to monitor the contractions and fetal heart rate. Serial cervical exams are also done to identify the extent of cervical dilatation, the position of the fetus in relation to the ischial spines, known as fetal station, and the extent of cervical effacement, that is, the shortening and thinning of the cervix. Fetal station is illustrated in the schematic on the right hand side here. The first stage of labor can be broken up into the latent and active phases. The latent phase is defined by slow cervical dilatation up to 6 centimeters. The mother's progress through the latent phase is monitored by the Bishop score, which is on the right hand side here. The score assesses the extent of dilatation, the position of the cervix, the degree of effacement, the fetal station, and the cervical consistency. The active phase is from the 6 centimeter mark to full cervical dilatation at 10 centimeters. The full first stage of labor typically lasts between 10 and 14 hours for a nulliparous woman, that is, a woman having her first child, and 5 to 8 hours for a woman who has had a child before. The second stage of labor lasts from full cervical dilatation up to the time of delivery. It involves the 7 cardinal movements of labor, that is, engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. These movements, in part, are illustrated through the schematic on the right hand side. The second stage is where positions and maneuvers may be required to increase the ease of delivery. For example, in the case of shoulder dystocia, where the baby's shoulder gets stuck against the birth canal, preventing its emergence, a maneuver such as the Merker-Roberts maneuver may be employed to increase the ease of delivery. The second stage of labor typically lasts 1 to 2 hours in nulliparous women and can be as short as 5 minutes and up to an hour in a woman who has had a baby before. The third stage of labor is the delivery of the placenta, and this occurs 5 to 30 minutes after birth. This stage can be managed either naturally following the normal uterine contractions or actively using oxytocic drugs, early cord clamping, and cord traction in order to deliver the placenta quickly. The aim in active management is to reduce the risk of postpartum hemorrhage and is especially a consideration in high-risk cases like multiple pregnancies, polyhydramnios, placenta previa, and induced labor. The fourth stage of labor is the first 2 hours postpartum. Here, baby checks are performed, vitamin K is administered, and there is plenty of skin-to-skin contact between mother and child. Some further considerations include pain management, the use of tocolytics like tobutylene, and the use of oxytocin and its analogues. The mainstay of pain management in labor is epidural analgesia. A combination of opioid and local anesthetic is released into the epidural space at regular intervals, and there is also an associated means for patient-controlled analgesia, or PCA. If the woman in labor feels that the regular release is insufficient, the PCA allows her to get an additional bolus of opioid and local anesthetic released into the epidural space, on top of what is already released at regular intervals, in order to help control her pain. Note that in caesarean deliveries, pure spinal anesthesia is typically used, so not epidural anesthesia. Inhaled nitrous oxide may be used, but this is less common due to concerns over side effects such as concerns over fertility, preterm birth, and B12 deficiency. Sterile water injections might be used to manage low back pain during labor, and warm compresses can be used for perineal discomfort and to reduce the risk of perineal tearing. Tocolysis is used to delay labor when it is pretermed, such that important treatments like antenatal corticosteroids can be administered. But these tocolytic drugs are not routinely used. Oxytocin or its analogues, or potentially alternative medications like ergometrine, can be given to augment contractions if considered necessary by the treating team, and therefore help enhance the progress of labor. So that's it. Thank you for watching. I hope that was useful. Remember to like, subscribe, follow us on Instagram at MidnightMed1200 for more, and we'll see you in the next video.